Good afternoon, everyone. iTech welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is Approach to Children Living with HIV, and speaker is Dr. Anju Seth. Dr. Anju Seth is currently working as Director Professor of Pediatrics and Program Director of PCOE Kalavati Saran Children's Hospital in New Delhi. She is actively involved in care of CLHIV since last 11 years. She is a member of the Technical Resource Group PPTCT in NACO, National Core Group on Elimination of Mother-to-Child Transmission of HIV and Syphilis, and a Master Trainer for training programs in HIV care. She is a member of many NACO-constituted expert groups, including Expert Group on Development of Nutrition Guidelines for HIV-exposed and infected children and infants, Expert Group for Revision of Pediatric HIV Guidelines, and Viral Load Expert Committee. She was a core committee member for development of nutritional counseling module for adults and children with HIV. We welcome you, madam, for today's NDLS session. I would request Dr. Seth to kindly take over the session now.
Thank you, Divya, and good afternoon, friends. It's a pleasure to be interacting with you once again. So today's topic is, it's a pediatric topic, of course, and what I'm going to deal with is how do you initially evaluate a newly diagnosed child with HIV infection? How do you So we will talk about the various issues that might be important here in the initial evaluation of a child, and the key activities that we need to undertake before the child is ready for antiretroviral therapy. Next slide. Okay, so we will begin with a case study of an actual child. Of course, the identity of the child has been masked, and unfortunately this child is no more. Rest of the facts are true. So this child was presented to us at the age of 6 years. He had a generalized skin rash, which you can see. Pointer, which you can see on his body. He had a generalized skin rash, and look how emaciated he was. He also had bilateral chronic ear discharge, and you can see his nails. His nails show the evidence of fungal infection in the nails. He was very malnourished. What I have shown here is the standard deviation scores, and for this, just to clarify to my colleagues who may be unfamiliar with this, we measure in children because height and BMI are dynamic. They depend on age of the child. We have age specific reference data available, and we calculate the standard deviations from the median. So if the height of the child is below -2 standard deviations, then one can take that the child is stunted. Likewise, a BMI of less than -2 standard deviation would indicate a low BMI. I often talk about measuring and interpreting growth parameters when we talk about growth monitoring in children with HIV. So what it means is that this child's height was at -2 standard deviation, so he was just at the level of being stunted, and his BMI was relatively on the lower side but well maintained. He was not wasted. His father had died of unknown illness 2 years back. So this child, because of his clinical set of findings, was found. We did a HIV test at my institute, and the child was found to be ELISA positive. And at that stage, mother disclosed on direct questioning her own HIV positive serostatus. Okay, so here we are, a new child who has now been referred to the ART center. So as a medical officer, if such a child approaches you, comes to your center, what all should you be doing? Let us first see what is the objective of our evaluation. Our objective is to determine the clinical stage of HIV infection. We would like to identify history of past illnesses that may be relevant for this child, which may or may not be related to HIV. For example, does he have a history suggestive of recurrent systemic infections, especially pneumocystis pneumonia or tuberculosis in the past? Our objective is also to identify the current HIV related and other illnesses, which again would include TB, because these illnesses would require management, and they may also influence the choice of ART. They may also influence the time at which when we start the ART. If we suspect any opportunistic infection, then diagnosis and treatment of opportunistic infection would take a priority over ART initiation, and based on the information that we gather, we would have to determine the need for antiretroviral therapy and OI prophylaxis according to the age, our clinical stage, and or CD4 count and percentage. So this is our objective of initial evaluation of a child. And before we evaluate further, let me reiterate, it is very important to have a HIV positive report from a ICTC center. So a lot of time patients may come to you with a report from a private lab. It is always good before you enroll them in your system. In fact, it is mandatory that you do have a report from our own ICTC center. So how do we diagnose? How do we assess a child? A newly diagnosed child with HIV, I would very strongly recommend to have a pre-formed structured proforma. I think it's very good to have a structured proforma even for adults, but for children we always have a structured proforma where the key components would include on anthropometric assessment, a detailed clinical assessment which includes history and physical examination. Development is an integral component of assessment of any child in general, and a child with HIV infection in particular, because the HIV virus is a neurotropic virus and can have a direct influence upon the child's development. And then we have some lab assessment to be done, and also don't forget psychosocial assessment of the child, the environment from where he comes, and the family is important. Okay. And of course, based on our clinical assessment, we would do a clinical and immunological staging, and this would determine the eligibility for ART. So let's come to the details of history that we need to take. We need to take a history of HIV specific symptoms, and which, as we all know, would relate to infections. So present and past, what is the duration? So since when has it's a good idea to begin since the child was last well, and since then what all illness have happened, what has been their severity of illness, how many times has the child been hospitalized. Try to review as many records as you can get, the previous medical records of the child, what all treatments have been given to the child, and those records sometimes also give you the child's weight and height, so that will give you opportunity to record his previous parameters. When you make a growth chart for him, you can plot the previous parameters as well, so that helps you interpret the current parameters in a more holistic way. So review all medical records, take a very thorough history the first time around and document it. And in infants and young children, it's a good idea to begin from birth, so that you know when the child became symptomatic and what all illnesses he's had since then. And as you all know, in the current times, it's extremely important to be screening all HIV infected children with the four symptom screening for TB. So that would be relevant here as well. So look for current cough, fever, poor weight gain, and contact history of TB. A thorough past history, TB, repeated infections like diarrhea, respiratory tract infection, oral thrush, ear discharge, skin infection, jaundice, and for all this, how severe were they? Were they managed on an outpatient basis, or did the child require admission? Where was he admitted? What was the duration of sickness? Try to get as many details and capture it in one comprehensive case record. Record the treatment history, previous hospitalizations, blood transfusion, treatment for coexisting medications, any antiretrovirals taken in the past, any herbal drugs, any concomitant medication. Take a birth history, gestation, birth weight, perinatal period. Take a retail feeding history. Is the child, depending on the age of the child, if it's a young infant, then we would like to know whether the child is being breastfed or top fed, and if it is top feeding, what kind of feed is being given, and when was the complementary feeding introduced. And in an older child, we would like to know what has been the dietary history of that child, and we would do it pretty much the same way as do it for other children. So by 24 hours dietary recall method, before the child was last sick, and if he has always been sick, then what he has been taking at present, we would like to know that. So because this directly helps us in assessing how sick the child is, it helps us in planning the dietary rehabilitation of the child. A detailed developmental history is again important. So what we would like to know, if it's a young child, has he achieved the age appropriate milestones or not? So is there a delay in milestones? There could be different kind of patterns. You could have a child who started off very well early, achieving milestones normally, and at some time he is kind of staggered off, in the sense he is now he is not gaining very fast. He was gaining well earlier, but now he is gaining them slowly. This kind of a pattern may be seen in, say, a child who has, say, recurrent acute illnesses. Say if he is doing well till 7 or 8 months of age, has achieved milestones, and then he develops an episode of diarrhea. After that he develops maybe another episode of diarrhea, maybe he develops an episode of measles. So at that time, because of recurrent episodes of sickness, his further attainment of milestones gets delayed. So that's one kind of pattern. The another kind of pattern may be that the child has achieved some milestones, and after that he has gradually lost the milestones that he has already achieved. That is something known as developmental regression, and that can both, I am trying to differentiate between both these patterns, because both kind of patterns can be seen in a child with HIV. While a child with recurrent infections may show slowing of attainment of new milestones, a child with HIV encephalopathy might show a loss of previously acquired milestones. So this child may gradually lose what he had already achieved. A third kind of pattern may also be seen, and this third kind of pattern could be a child who is achieving his milestones nicely, but now he develops a acute CNS illness, which could be acute meningitis, which could be tubercular, which could be cryptococcal, or which could be even bacterial meningitis, and as a result of that illness he suddenly goes back. So a child who was able to stand and walk develops meningitis, and after that becomes bedridden. So all these different kind of patterns of regression may be seen, and it's a good idea to take a detailed history and find out exactly what has happened. Take a detailed immunization history. This will help us in planning the child's immunization if he is unprotected in some way. We need to take the maternal history, as you are all aware that most of the childhood HIV is through transmission from the mother, either during pregnancy, perinatal period, or in the postnatal period. So good idea to know maternal history, her age, her parity, pregnancy and labor details, her own HIV status, what is her clinical stage, CD4 count, ARV prophylaxis or ART. Now of course you know that we give ART to all mothers right from pregnancy. So whether she was started on ART, when was she started, and is she compliant with her therapy or not? What are the illnesses that she has? Is she being treated for tuberculosis? Does she have any other OIs? So, and in general, what is her own health status? You would like to know that, because a lot of time mother is the primary caregiver of the child as well. So one would like to know what is the maternal own health like. Likewise, we would also like to know about father, the age, the profession, his health status. Does he have TB? Does he have other OIs? Is there a serodiscordance? Is the father HIV negative, that is? Or if he is positive, what is his own status of antiretroviral treatment? It's also good to inquire about other siblings. Remember, HIV, especially when it involves a child, often is a disease that is occurring in the family. So good to identify who are the other family members. Have the other siblings been checked at all? And if the other, this is the opportunity to check other siblings. And because sometimes it happens that this child became symptomatic and we have tested him and found him to be positive. He might actually be having an older sibling who may be a slower progressor and therefore has still not been brought into the loop. So use this opportunity to check HIV status of other siblings if that has not already been checked, and what is their current health. Another important thing in history is, in case of parental death or sickness, who is the caregiver of the child? That is another important thing we need to know. And finally, what is the socio-economic status, which of course is going to impact upon multiple issues, the social milieu from which the child comes, the education, the financial issues, etc. So all these components of history, which are the usual components of pediatric history, get a little modified as per the needs of a child with HIV infection. So I would, as I said earlier, and I would reiterate, that it's very good to have a structured pro forma and at least once take a very detailed complete history of the child, and that document becomes your permanent record for future reference if required. So once we have taken a history, we come to the examination. So we will take the child's weight, length or height. I hope at all ART centers We have a height meter and a infantometer. They are not difficult to get. They are not very expensive. I would urge all of you very, very strongly to have not only a weight scale but a height scale and also a infantometer for length. Good idea also to keep a measuring tape so that you can measure the head circumference and you can measure the mid upper arm circumference. That's the short form. MUAC that you see here is the short form for mid upper arm circumference that you see here. Okay. So once we see measure these parameters, at least it's very good to at least record, have a growth chart and record the child's weight for age. Record it then and use it for future recordings as well. And on different occasions I have talked about growth monitoring in children and how maintaining such a growth chart really helps you learn a lot about the child and how he is doing in future also. So please measure the weight, height, BMI and the MUAC, and we can these days we also have very nice apps available and we can actually calculate the Z scores for the weight and height of the child for people who are interested in doing that. But the least I would recommend is maintaining a weight for age chart. Good idea to record the height and periodically measure height as well, because what we see, children with HIV do have a lot of stunting. So apart from anthropometry, look for fever, anemia, any signs of vitamin deficiency. Look at the eyes for conjunctival or corneal xerosis, angular stomatitis, skylitis, any signs of rickets, vitamin C deficiency. Remember, these children have a compromised nutrition and malnutrition is very common, and where there is malnutrition, vitamin deficiency will coexist. Look for clubbing. Clubbing would in such a child would indicate any chronic disease, especially presence of bronchiectasis, especially presence of any other chronic, even chronic HIV per se can cause clubbing, and edema, lymph node, dermal manifestations. A lot of dermal manifestations may be present, especially in clinical stage 2 of HIV, which could include nutritional dermatosis, which could include disseminated skin fungal infection. We did show the picture of Rahul who had disseminated skin fungal infection. And even nutritional dermatosis can be seen where there are just ulcerations in the skin along the trigenous folds. There might be a candida infection. So look at the dermal manifestations, look at the ear discharge. A child with intermediate progression might come with parotid enlargement. Examine for oral thrush, jaundice, and examine all systems in detail. Look at the chest. Are there, what in our own experience we have seen a lot of bronchiectasis in children with HIV infection, and acute infections of course are again very common. So a good thorough evaluation of chest is important to pick if there is any current chest infection, which could also be a manifestation of tuberculosis also. And lymphoid interstitial pneumonitis, remember, can also present in children with who are intermediate progressors. So chest involvement is important. Look at abdomen. Is there any hepatosplenomegaly? Is there any ascites? Any symptoms of Cox abdomen? So there could be presence of a doughy abdomen, presence of ascites, organomegaly. Look at the CNS, including development of assessment, CVS. So complete your physical examination. So having done that, there is some essential lab workup that is needed for every child with HIV, and this is what we need to do. We need to do a complete blood count, LFT, KFT, serum electrolytes. As you are aware, we always do CD4 count, and in children less than 5 years, we would also like to look at CD4 percentage, because in young children, CD4 percentage is a more reliable indicator of immunodeficiency as compared to CD4 count, which in general tends to be higher in children. And every child must undergo a testing for hepatitis B and hepatitis C, because presence of these co-infections substantially impacts upon the morbidity as well as the treatment. A fundus examination for CMV retinitis is highly desirable at this age. TB screen should be done for all patients. So we would do XHS and Montux for all patients. And remember that a lot of children, because they are immunocompromised, their Montux test may be negative. So a lack of induration in a Montux test does not rule out tuberculosis. However, if a child has a Montux which is positive, and in a child with HIV infection, even a 5 millimeter induration is significant. In a child who is non-immunocompromised, we would look at a 10 millimeter induration in the transverse direction. But in a child with HIV, if the induration is just even 5 millimeter, it indicates very strongly presence of an active disease. And if apart from that, any other, as indicated by symptoms, a search for TB is really important. So we might like to do, if there are lymph nodes, the FNAC from the lymph nodes, if there is ascites or pleural fluid, checking of the pleural fluid, and ultrasound abdomen to look for retroperitoneal lymph nodes or bowel thickening. We would send gastric aspirates for AFP and also for CBNAT. You're all aware now CBNAT is available in the systems, and CBNAT would help pick up TB by checking specimens, not only sputum but also pus aspirate, FNAC samples, gastric aspirates, and even other body fluids. So availability of CBNAT has increased our diagnostic yield of tuberculosis. So every attempt must be made to achieve microbiological diagnosis if possible. We may still not achieve it in all children with TB, but it is well worth the effort. And of course, the advantage of CBNAT is it also tells us the rifampicin sensitivity of the tuberculous organism that the child is harboring. So that also helps us in planning the therapy. So apart from TB screen, urine routine and microscopic examination, and if directed by symptoms or urine microscopy, a urine culture is desirable. Fasting blood sugar and lipids, especially if the child is going to go on a PI based therapy. And then symptom and sign directed tests. So whatever the symptom the child has come with, though they might also direct our testing. So if a child has come with persistent diarrhea, we might like to evaluate the stools of the child. And if a child has chronically discharging ears, we may like to send a pus culture and so on. So once we have done a history examination and a basic lab evaluation, at this stage we would like to do the clinical staging of the disease. This clinical staging would help in predicting the disease progression and mortality. It is also a guide to start cotrimoxazole and antiretroviral therapy, especially when CD4 count is not available, and it helps in monitoring response to therapy. So we would always like to know the clinical stage of the disease, and you would document it in your records. Your white card also has a provision for recording the clinical stage of the disease when we are when the child is first evaluated. So if just for our revision, a clinical stage 1 in children is either when the child who is seropositive is asymptomatic, or if he has a persistent generalized lymphadenopathy. That's a clinical stage 1. A child with clinical stage 2 would have hepatosplenomegaly, a wide variety of dermal infections, could be herpes simplex, could be herpes zoster, could be candida infection, etc. Parotid enlargement, and recurrent or chronic upper respiratory infections like otitis media, sinusitis, tonsillitis. These are the key components of clinical stage 2. So some of the pictures, and this slide is from the NACO training module. So you could look at the herpes simplex here, the extensive warts in this child, molluscum contagiosum, parotid enlargement, hepatosplenomegaly. So and these are all suggestive of HIV clinical stage 2. What about clinical stage 3? The clinical stage 3 would be characterized by unexplained moderate malnutrition, and by moderate malnutrition we don't look only for weight, we also look for height. So a child who has weight for height or BMI between -2 and -3 standard deviation, or a height which is between -2 and -3 standard deviation, can be classified as having moderate wasting and stunting respectively, and either of them would classify a child as moderate malnutrition. So a child who has a BMI Z score between -2 and -3, or a height z-score between -2 and -3 would be considered as having moderate malnutrition. Unexplained persistent diarrhea, unexplained persistent fever, persistent oral candidiasis, pulmonary or lymph node TB, severe recurrent bacterial pneumonia, lymphoid interstitial pneumonitis, chronic HIV associated lung disease including bronchiectasis, and hematological findings, unexplained anemia, neutropenia, thrombocytopenia. These are the key components of clinical stage 3 of HIV in children. The clinical stage 4 is characterized by severe malnutrition. And again, what do we mean by severe malnutrition? Again, we go by two parameters, weight for height or BMI. If these are below -3 z-score or below -3 standard deviations from the median. So if BMI or weight for height is below -3 standard deviation from median, the child is said to be suffering from severe wasting. Or if his height is below -3 standard deviation from the median, the child is said to be suffering from severe stunting. And both severe wasting and severe stunting can be classified as severe malnutrition. So a child with moderate malnutrition would be clinical stage 3, while a child with severe malnutrition would be clinical stage 4. Apart from that, pneumocystis pneumonia, recurrent severe bacterial infections, and these are systemic infections here, extrapulmonary TB, esophageal candidiasis, CNS toxoplasmosis, systemic CMV infection, extrapulmonary or disseminated cryptococcosis including cryptococcal meningitis, disseminated endemic mycosis, cerebral or NHL, B-cell NHL, and presence of HIV encephalopathy, nephropathy and cardiomyopathy would place a child in clinical stage 4. As you see this classification, you can understand how important it is to thoroughly assess a child clinically. If you do not do the anthropometry, you will miss diagnosing malnutrition. If you do not take developmental history, you might miss picking up HIV encephalopathy. If you do not look at fundus, you might miss CMV retinitis. So it is very important to thoroughly evaluate a child clinically. And if you find a problem as a medical officer, do not hesitate to take a pediatrician's opinion initially. A good holistic evaluation of a child at presentation is critical for you to identify all the issues and manage. Another important thing is what I have tried to show is just some key components. There is no need to remember the clinical staging. Just keep it at a readily accessible place and refer to it as required. So one need not really remember too many things. Just keep them accessible and refer to them. Remember to refer to them. And over time you may actually start remembering most of it. But don't waste your energies actively trying to mug up these issues. So these are some of the pictures showing HIV clinical stage 4, the HIV wasting, the pneumocystis pneumonia. Of course, this X-ray could indicate a lot of other illnesses apart from pneumocystis, but this particular X-ray is from a child with pneumocystis pneumonia. So once we have done the clinical staging, we also look at the immunological staging. And remember, the immunological staging in young children up to 5 years of age, we would always look at the, you see here, we would look at the CD4 percentages. Okay. So it's only, we have the columns here, less than 12 months, 12 to 35 months, and 36 months to 59 months. So under 12 months till 3 years of age, and then 3 years to 5 years of age. So all here, what we are showing are the CD4 percentages. What we are showing here are the CD4 percentages. And what we are showing in the column for child more than 5 years is the total CD4 count. Okay. So again, one need not remember, one can always look at this table and classify the child's immune status. So the whole idea is that you are able to holistically place a child that this is the clinical stage and this is the immunological stage, because as we talk later, as I go on with my talk, you will realize earlier we were using clinical and immunological criteria to decide the need for ART, and situation is quite different today, and I will be talking about it in the subsequent slides. But still, it's a good idea to do a clinical and immunological staging so that you have one baseline parameter which you can track over time, how the child is behaving as when you give him ART. Is he improving? Is he worsening? So you need a baseline parameter to compare with. That is why it is important to do this and document. So coming back to our child with whose case study we started. So this child, Rahul, had dermal candidiasis. He had chronic otitis media, placing him in clinical stage 2 of the disease. He had a CD4 count of 700 cells per mm cube. And now, if you remember, in today's date, tell me, what do you people think? Do you think he is eligible for ART in today's date? He is not. He is not eligible because in today's date, we are starting ART in a child who is less than 5 years of age, irrespective of clinical and immunological stage. But if a child is beyond 5 years of age, we are starting ART only if he is in a clinical stage 3 or 4, or if his CD4 count is less than 500 cells per mm cube. Again, these are very dynamic decisions, and over the last few years, our threshold for starting ART has progressively come down. And even while we talk of this, while I'm taking this session, a lot of you would be aware that we are very, very close to launching the test and treat policy, which means that very, very soon we would not have any period of so-called pre-ART when a patient would be maintained for some time waiting for him to meet the criteria to start ART. That will soon be a thing of the past. Every patient, whether it is child or adult, would become eligible for ART as soon as he is diagnosed. So we are reaching that stage now. But as of now, this is what we are doing, and the presentation today is entirely in that context, that this particular child does not meet the criteria to start ART as per today. If he was less than 5 years of age, or if his CD4 was less than 500, he would have been eligible to start ART. So this child is not eligible, and therefore he was maintained, or rather initiated, on pre-ART phase, and we'll talk a little bit more about it. He was treated for his candida infection. His ear infection was taken care of. His nutritional rehabilitation was started, and as you will see later, he is not a candidate for cotrimoxazole prophylaxis, again because of his immune CD4 count, which is relatively well maintained. So what do we do with him? We put him in something known as pre-ART phase. And what exactly does pre-ART care mean? Pre-ART care technically means care of people with HIV prior to initiation of ART. As I said, in today's date, all PL-HIV do not need immediate ART initiation, which is guided by clinical and immunological criteria. However, care is to be provided to all PL-HIV irrespective of their immediate eligibility for ART. The objective of pre-ART care is to optimize the health and delay the progression of clinical stage and maintain the immune state to the extent possible, so that we can keep him as healthy as possible for as long a period. So even when we are on the brink of just starting test and treat policy, the importance of pre-ART phase does not go down. When we say test and treat policy, it doesn't mean that the moment you see the patient, you put him on ART. All the initial steps that we have talked about, for example, if it is taking care of his opportunistic infections, if it is taking care of his any immediate needs, whether it is or taking care of his diarrhea, or beginning his nutritional rehabilitation, all these would still be there, and all these components will remain as relevant as they are in the present era, as they would be when we will not have any defined pre-ART care. So that the components still remain relevant. Just keep that in mind when we start with test and treat policy. And it's good that now we have started to do test and treat, because what has been our experience and also experience of people elsewhere, that this pre-ART phase is a very vulnerable phase for LFUs. So if we look at our own data, our LFU rate in the pre-ART phase was 9.6% as against 4.3% in patients who were started on antiretroviral therapy. So one of the advantages of test and treat policy would be that LFU rate would go down. So what do we do in pre-ART? So once we have done the baseline parameters, we would like to do a periodic, every visit, a growth assessment of the child. Again, as a pediatrician, I cannot emphasize enough the need for proper anthropometry. It tells us so much about the child. Maintain at least a weight for height chart. Wonderful if you can maintain a height for age chart also. You would see the new NACO training modules. And in fact, we are now in the process of revising the NACO guidelines on antiretroviral therapy, and soon you will see the type of growth charts we are recommending. What we are recommending are growth charts based on WHO reference data till 5 years of age, and beyond that growth charts by the Indian Academy of Pediatrics. These will soon be made available to you for use. Keep them. These are available on the internet also. Print them, attach them to your patient's file, and please maintain. We have combined charts of, I'll show them to you, weight and height also. So maintain those for children. So do a periodic anthropometric assessment, maintain a growth chart, and this longitudinal record, if you can manage to maintain it, is the most sensitive indicator of the well-being of the child. So a child, if he is growing well and continues to grow well, is a very positive indicator that nothing is seriously wrong with the child. On the other hand, if he has growth faltering, beware, evaluate this child, things may be going wrong, which could be anything, which could be appearance of a new OI, which could be a progression of HIV itself, which could just be a manifestation of family stress, malnutrition, so many things. Okay, so I have a question here. How is BMI done in pediatric patients? Look, what I would recommend is for children up to 5 years of age, look at weight for height. If you go on the website, this question is from Bhubaneswar, it's a capital hospital, Bhubaneswar. If you go to the WHO site website and you feed in growth reference standards, you will be able to download a table which shows the weight for height standard deviation scores. So separately for boys and girls, and those will give you for boys and girls separately what is for a particular height, what is the ideal weight, and what are the various weights at -1 Z score, -2 Z score. So straight away you can pick up wasting. In a child beyond 5 years, we calculate BMI, which is weight in kg upon height in meter square, the standard phenomenon. The difference from adults is BMI in children is again it's a dynamic. It doesn't remain constant at all ages. So we have the way we have weight chart and height chart, we also have BMI charts. And you can again, IAP BMI charts are there. In fact, there are apps. There are beautiful apps which you can download on your mobiles, which will calculate the BMI Z scores for you according to Indian Academy of Pediatrics. One of those apps is known as AnthroCal, ANTHROCAL. I repeat, AnthroCal, ANTHROCAL. Very user friendly app. We also have a IAP growth app also. So both of them, if you can have in your mobile and you start using them, that will help you calculate the BMI Z scores. So it's a very useful tool to have. There is another question. 3-year-old female child, she was tested 5 times and in that she found positive 2 times, negative 3 times. Mother ART center. ART till further instruction. Please. Okay, so this question is from ART center at Chalkaranji. See, this is a little different from the topic today, but I will respond to this on email. I'll request Divya to take note of this, and I will definitely respond to this on email. But right now may not be a good time to talk about it. Right now, let us talk about issues which are directly relevant to the topic that I am taking. And other questions, you're most welcome to write to Divya. She will forward to me, or you can write to me directly. No problem at all. Okay. So again, so what is the significance of growth monitoring in children? Coming back to my topic, you can pick up overall well-being or presence of some problem as we thought. So if a child's growth is faltering, it could indicate nutritional deficiency, could indicate a OI, could also indicate stage of HIV. Remember we talked about moderate malnutrition being stage 3 and severe malnutrition being stage 4, could also indicate psychosocial issues. So remember, these children come from very stressed families. And so is it that the parents have become sicker? Is it that the father has lost a job? Is there a change of caregiver? A lot of issues might impact upon the child's growth. This also, a growth chart also helps us track the effect of intervention. So it is actually a surrogate marker of response to antiretroviral therapy, maybe treatment of infections including tuberculosis, nutritional rehabilitation. In fact, when we review the cases for our SASEP, one of the important parameters I insist on seeing is show me the growth parameters of the child, how they were at presentation and how he is behaving. A very look at growth parameters is a very important clue as to when the child started deteriorating. So on the other hand, if a child is maintaining his weight for age and height for age Z scores, I can say that this child grossly is not so sick. Whereas a child whose weight and height are Z scores are faltering, I will be very suspicious there. So growth charting will help in understanding, is the child well or is there some problem, and also for tracking the effect of intervention. So these are the parameters we would like you to measure. Measure weight every visit at ART center, length for children up to 2 years, height for children beyond 2 years. In young children up to 2 years of age are growing very fast. Measure length every 3 monthly. Height measure every 3 monthly for up to 5 years, and beyond 5 years, because the rate of growth slows down, measure every 6 monthly. Very convenient. Mid upper arm circumference, you don't, when you're measuring weight, height and calculating Z scores, you don't really need a MUAC. MUAC, you can measure it and record it, that might be additional parameter, but critical importance of MUAC is when when it is not possible to record height. And MUAC, some of you might know, is an age independent parameter of malnutrition. If the mid upper arm circumference is less than 11.5 centimeter, that indicates severe acute malnutrition. If it is between 11.5 and 12.5, it indicates moderate acute malnutrition. So MUAC is a surrogate for weight for height or BMI that we have been talking about, and we have standardized MUAC, these parameters that are set for child between 1 to 5 years of age. So if the MUAC is less than 11.5, the child has severe acute malnutrition. If it is between 11.5 and 12.5, the child is having moderate acute malnutrition. But as I said, desirable to measure, not essential if you are measuring weight and height. So this is a weight for age chart. As I said, up to 5 years, if we prefer using WHO charts. See what is this chart showing? On the x-axis, it is showing us the age of the child from birth to 5 years of age, and here it is showing us the child's height. Sorry, here it is showing the child's weight. We also have similar chart for height. 0 indicates the median level, that is the Beachwala value. -2 and +2 indicate the limits of normality. Remember the Z scores I was talking about? So WHO charts come in Z scores. So any parameter lying between +2 and -2 is normal. A child with weight for age less than -2 we call undernourished. With weight for age less than -3 we call severely undernourished. Likewise, if you were dealing, supposing this was a height for age chart, height for age chart would also have similar marking, except that you'll have age here, age at the x-axis, and the y-axis instead of weight you'll have height. So if you have height here, then this is the median height. Any child below -2 Z score would be stunted. Any child below -3 Z scores would be severely stunted. Likewise, if you have a BMI chart, so on y-axis you have the BMI plotted. This would be the median BMI. A child below -2 is wasted, below -3 is severely wasted. So this is the median value, this is the range of normalcy, and beyond that is what we have. What I've shown here are the IAP charts. So till 5 years we use WHO, beyond 5 years we use the IAP charts. The blue chart here is for boys, the pink chart here is for girls, and both these charts show two things. If you look at the chart for boys, we have on the x-axis is the age, on the y-axis we have two parameters. We have the weight, so the lower graphs we plot the weight for height, the weight for age, and on the upper graph we plot the height. So it's a comprehensive chart. It's a comprehensive chart where both weight and height are recorded for a child at different ages. And what you see here are not the z-scores, you have the centiles. So actually growth can be monitored as both. I think Praveen, there is some problem. There are a lot of people saying no audio. So I don't know, maybe they can see the link later. And I think Devangri and MMC ART Center, no audio. I suppose they can see it later. So yeah, coming back to this, here instead of z-scores, we have plotting in centiles, which is good enough. So 50th centile means the central line indicates the median or the central value. As we said, the z-score normalcy is between +2 and -2 z-score. Here, anything which is below the third centile, this is the lower third centile, is what is less than normal. So anything between third centile and 97th centile, third and 97th centile roughly correspond to 2 z-scores. So third centile corresponds to -2 z-score, 97th centile corresponds to +2 z-score. So anything in between those two is normal, anything beyond these two might be clearly beyond normal. So these are the growth charts which you can use for children beyond 2 years of age. Again, you can download them freely from the internet, the WHO chart, the IAP charts. You can very easily download them and you can use them in your routine practice. Start using them, you'll find how wonderful they are. So this is just to show for your own benefit. We assess the nutritional state of HIV infected children at presentation in our own center. So what we found was that our children at presentation were, this is the average weight for age z-score, was -3.2. What does it indicate? That most of our children had severe wasting, right? This is weight for age. I'm sorry, this is weight for age. So most of our children were severely undernourished, which is just weight for age. Anything below -3 z-score would be severe undernourished. When we looked at their height for age, the median z-score was -3. Again, what does it indicate? Most of our children were stunted. Anything below -2 z-score is stunted. Anything below -3 z-score is severe stunted. And look at our BMI. BMI z-score, the average z-score was -1.9. So what does it indicate? It indicates that our children in general at diagnosis were very stunted. But their relative weight for height or BMI was maintained. So they were not severely wasted. Remember, wasting is when BMI is less than -2. So the average BMI z-score was -1.9. So our children were not really wasted, but they were short. And this is, I'm sure, is the experience for most of the people who are maintaining these records as well. In fact, right now we're in the process of publishing our longitudinal data on the growth parameters of these children at presentation and subsequently on antiretroviral therapy. We have very good data on how these parameters change as a patient goes on ART, and that data is under publication, and we'll be very happy to share the published paper with all of you to learn from it. So apart from measuring growth, pre-ART phase is an important phase for assessing and treating nutritional deficiencies. So look for anemia. You have a hemogram available, please treat anemia. Look for vitamin deficiencies and treat. Assess the diet and provide appropriate nutritional counseling. Very, very important in children. Time? It's okay. Do nutritional counseling so that child can maintain his status and recover from nutritional deficiency. Remember, a malnourished CL HIV, we have documented proof, have a faster rate of progression of disease, have higher mortality, It is well known that mortality from severe acute malnutrition is more than 3 times higher in HIV positive children as compared to their HIV negative peers. Okay, and a lot of severe acute malnutrition related deaths occur within 1 week of admission, indicating advanced stage of disease at presentation. So all this I really hope would change once it has already changed, because now we are treating all children under 5 years of age. And so, and now once we start test and treat, we really hope that we are able to catch these children before they become severely malnourished. And that would be a triumph of the program if we are able to prevent deaths, if we are able to prevent severe malnutrition. That's a huge gain. Okay. So just to share with you, the energy needs of HIV infected children are more than what they are for a child without HIV infection. So if a child is generally doing well, then also he needs 10% extra energy as compared to a non-HIV infected child. But if this child has poor growth or weight gain, or he has associated TB, persistent diarrhea or chronic lung disease, he requires 20 to 30% extra calories. And a child with HIV who has severe malnutrition may require as high as 50 to 100% extra calories. While the first two categories are obviously managed on an outpatient basis, this particular category, SAM, severe acute malnutrition with HIV, requires admission and needs to be given therapeutic feeding. Okay. So other nutritional deficiencies and supportive measures include adequate micronutrient intake. So we need to counsel them to improve their diet, to have a balanced diet. It's desirable to give a multivitamin preparation. Give vitamin A and iron folic acid supplements, and deworm 6 monthly. This will generally maintain a good health of the child. Okay, I see a lot of questions, but I also have a bit of presentation remaining. No problem. All your questions I'll request Divya to mail to me, and I will answer all of them. Unless I have time in the end, and I'll try and look at it. Very important to do developmental assessment, because virus can damage the developing brain. HIV infected children are at a high risk of developing HIV encephalopathy and severe neurological disease. Early identification of developmental delay and neurological abnormalities will facilitate remedial intervention. Very important to watch for delayed development and loss of previously acquired milestones. So there are some red flags in developmental screening. So watch out for these. Has the child lost what he had gained earlier? If a child who could walk earlier is not able to walk. Do the parents have any concern about the child's vision? Is he able to fixate on an object, and is he able to follow an object? Does he not seem to be recognizing or following his patients? Is there a hearing loss? Does the child feel floppy? Does he have a low muscle tone? Does he have no speech by 18 months? Does he have asymmetry of movement? For example, he is using one particular hand preferentially. Remember, a child's handedness is not developed till good 3 years of age. So if a child shows a preference for hand use during his infancy, that might alert you that there might be a neurological issue there. Does the child walk on toes? Does he have any complex disabilities? And here comes the importance of measuring head circumference. Does he have microcephaly? A head circumference below 3 st indicates microcephaly, and beyond plus 3 st indicates a large head, which could be again due to various causes including hydrocephalus. So these are some of the red flags in development that we should watch out for. Likewise, if the following activities are not achieved in a child, which include sitting unsupported by 12 months, walking by 18 months, walking other than on tiptoes. He can walk only on toes of his feet but not with his feet put down. Running by 2.5 years, holding objects placed in his hand by 5 months, and reaching out for objects by 6 months. These are some important milestones. If a child has not reached them, then watch out. In fact, your module that we are now preparing will give you a development screening tool, which will just tell you the normal time by which most milestones should be achieved, and that will help you pick up a child who is delayed in his milestone. So use that tool, and it would be there in your previous NACO guidelines, and we have also included in the new guidelines which are under development right now. So you can use that to help you assess the development of the child. But remember these red flags, which are few, and that can quickly help you pick up a child with developmental delay. Look at the immunization of the child. Remember, there are a lot of immunization issues. These children need to be immunized because they are more susceptible to infections, right? They are immune compromised, they can develop more serious complications, therefore they need vaccination. However, keep in mind that success of vaccination may be suboptimal depending on the extent of immunodeficiency of the child. So in general, so there are two issues. One, they need vaccination. Secondly, they may not respond to vaccination because they are immune compromised. And thirdly, if we are using live attenuated vaccines, we are a little worried that is the live attenuated vaccine safe in them? So in general, all inactivated vaccines can be administered safely and should be given at the right time so that the child, remember, when a child is born, he may not be immune compromised. Over time, he becomes more immune compromised. So earlier you give it to him, better is the expected immune response. So all inactivated vaccines can be administered safely. Live attenuated vaccines are contraindicated in severely immune compromised children if the CD4 is less than 15%. Okay. However, there is enough evidence now to show that missed live vaccines can be given once these children are immune reconstituted after ART. So when we give them ART and we see them clinically improve, we see that their CD4 count is improved beyond 15%. Not only do they respond well to a vaccine which is given now, they will be protected as well. So in fact, we have done and published from our center study where we looked at the measles antibody titer in patients who were on ART. We found that most of our patients lacked the measles antibody titers. That means they were not protected against measles, even though most of them had received measles vaccine as a child. In such a child, we then we gave them measles vaccine because they were immune reconstituted. We gave them MMR and we measured the response to measles component of MMR, and more than 90% of the patients achieved a short-term immune protection against measles. That paper is published, and I'm sure if you search for it, Anwar has circulated it earlier. I'm sure you can search for it and find it. So this is a good strategy to give vaccines once the patients are immune competent again. I do have a question. See, 6-year-old CD4 1500, CD4 percentage is 10%, no OI. If CD4 count is 1500, I would suggest in a 6-year-old don't go by percentage, go by total count. The current program says only if CD4 count is less than 500, please start ART, not otherwise. But remember, as we are talking now, very soon we are going to begin test and treat policy wherein this child will become eligible. So, what immunization should you give them? Give according to the national or state immunization schedule. Important to give all recommended vaccines at correct age, as a delay will increase the susceptibility of the child to illness as well as decrease the immune response to vaccines. So this slide just shows the current immunization schedule. I don't need to share it with you. This is available everywhere. And please give all the vaccines to the children. Remember, these are the special desirable vaccines which are currently not available through the program, and these include inactivated hepatitis A vaccine, pneumococcal conjugate vaccine, inactivated influenza vaccine, and varicella vaccine. These are not available through the program, but it would be very good to, if it is possible, if our patients can afford, or through any other means, if we can give it to them, that would be wonderful. Then next component of pre-ART care is cotrimoxazole prophylaxis therapy. You all know about that. Not only does it prevent pneumocystis, it also prevents other infections like toxoplasmosis, bacterial infections, diarrhea, and malaria. And these are the indications. We need to give cotrimoxazole to all HIV exposed infants or children. Till the diagnosis of HIV is definitely ruled out, we start it at 6 weeks. All children, infected children, and infants up to 5 years of age, regardless of CD4 count and percentage. All HIV infected children beyond 5 years of age, if they are in clinical stage 3 or 4, or if their CD4 count is less than 350 cells. So 3 or 4 or CD4 less than 350. And secondary prophylaxis. Praveen, I think I still have a few slides. Do let me know, shall I stop it here or should I continue? Just Praveen and Divya, please inform me. I'll do accordingly. So this is also an opportunity to treat the session is likely to extend. Okay, thank you. So Praveen, I'll finish in next 5 minutes. So pre-ART care, these are the common infections we see at our own place: lower respiratory tract infection, diarrhea. This is lower respiratory tract infection, this is diarrhea, this is chronic otitis media, this is pneumocystis, candidiasis, and skin infection. So this is a profile of OIs that we see at our place. Pre-ART is the time to treat, actively screen for and treat these infections. And when do you start ART? Finally, you start ART as of now in children less than 5 years of age, irrespective of CD4 count and clinical stage, and children beyond 5 years if the CD4 count is less than 500, irrespective of clinical stage, or clinical stage 3 and 4, irrespective of CD4 count. Again, new guidelines are likely to be implemented soon for test and treat policy. There is another question: is there any variation of BMI between sexes? Yes, there is. There is a difference in BMI. We have different reference norms for boys and girls. It is always recommended that you look at the age and sex specific norms. Okay, I think that should be my almost the last slide. So prerequisite for starting ART, remember ART is never an emergency. Manage opportunistic infections before starting ART. Identify primary caregiver, better to identify 2 of them, so that if one of them is not coming, you can have the second one. And prepare the child and caregiver before you start ART. Assess the family's psychosocial readiness for ART. Really, really important. Define a caregiver, ensure family and social support. Disclosure also becomes important here. No, it's never an emergency. Prepare them. So friends, this is my last slide. Just to re-emphasize what I've said throughout, entry of a child into a CL HIV program is the beginning of a long relationship. A thorough clinical and lab assessment is essential before beginning treatment for HIV infection per se. Identification and treatment of OIs and other comorbidities is done before starting ART. But that doesn't really mean you have to wait for that OI to be completely treated. Once a patient is nicely stable, you can begin nutritional rehabilitation. Once you've started nutritional rehabilitation, you can start on ART. So don't delay it too much, but priority is to at least initiate treatment. It is important to assess and optimize nutritional status, correct nutritional deficiencies, complete immunization and thus build immunity, assess family situation of the child and decide on a caregiver, and bond with the child and provide age appropriate counseling to child as well as the caregiver. And again, all this remains valid even when we begin test and treat policy. All these are still going to be done. So that is all today, my friends. Thank you. There is a question, is length and height different? I get very interesting pediatric questions. Very right. There is a little bit of a difference between length and height, and that is why we recommend that for children up to 2 years of age, we measure length, because what we have available are the length standards. For a child beyond 2 years, measure height, because our standards that are available are those of height. Sometimes it may happen that a child, a child below 2 years of age just will not lie down, but wants to stand. So if you want to, what you can do is you can measure his height, but to convert height to length, you add 0.8 centimeter. So length is a little bit more than height. Correction factor is 0.8 centimeter. So if for a child less than 2 years, you are measuring height instead of length, add 0.8 centimeter. Okay. And similarly, if a child beyond 2 years of age is so sick that he cannot stand, you measure the length and minus 0.8 centimeter to get the height. So that is all, friends. I look forward to your feedback, and if you have any questions, I will be very happy to answer them. Let them be emailed to me through Divya. Thank you.
Thank you, ma'am, for such a comprehensive session. Thanks to all the participants for patient listening. The answers of all the unanswered questions will be circulated along with the recorded link. Thanks again. I would request all the participants to kindly enter the e-poll, which you can see